Uh, Today's topic at the CME program is care of elderly in the general practice with a particular reference to dementia. So I have my good colleague Professor Asita and myself, and let me tell you in advance that this Asita and I have done this before to a different audience of all females at ladies college some time ago, and it was for the old girls of ladies college, so it was an appropriate audience to do it too. And I think they appreciate it a lot, and I hope they are practicing some of what we told them. Okay, so without further ado, and we have been given 90 minutes between Asita and myself, and we have been warned to stick to that, and both of us being lecturers, I'm sure they are scared that we might go over our time, so I'll assure you that we will stick to time. This is the overview of what Asita and myself will be doing today, with a particular reference to dementia, of course, about the diagnosis, that's the risk factors and how the patient presented, then what screening processes are available, and you'll be given a handout also about the screening and detection. Then diagnosis and assessment, Asita will talk about. Then promoting of independence of patients, the shared care when they come back to the primary care level, what we do. Then what are the current interventions available for dementia, pharmacologically, non-pharmacologically, screening, what's the latest data, Asita will tell you. And of course, palliative care. With regard to palliative care, let me just diverge for a second and tell you that this is a total coincidence. We have just concluded a 2-day certificate workshop with the Palliative Care Institute in Cochin, India. 2 of the resource persons who are here, so it is certainly not planned. And we had a huge audience at that palliative care program, and it was a certificate being awarded, and unfortunately it was not just given, you had to earn it. So we are waiting to see whether he has corrected the papers and whether some of us have indeed got through in the palliative care area. Right. So who are the elderly? Certainly I am also now elderly now compared to another section of the population, the kids and so on. So it's a relative thing. But in a scientific field, you can't be subjective. You've got to be objective. You have to have criteria to define an elderly and so on. So if you say retirement, ages of retirement even in Sri Lanka differ from place to place. And if you take the region and the world itself, it differs. So we have, there is a accepted definition for the old, that's the elderly, the young old, the old, and the extremely old. So those are the parameters which we use, and you will see its relevance in a few moments. And of course, the speciality of dealing with the elderly is geriatrics. And let me draw your attention to the underlined bold section in red. The principle of geriatric is to preserve function and to improve quality of life. So geriatric practice, the doctor must look not only into the medical problems, but also social and psychosocial, psychological issues and many other things. And let me tell you, the GPs are quite good at that. That's what we do for a living, in fact. And of course, a few other things. The elderly should not be excluded from any services due to a diagnosis, age, or any comorbidity. Why I say that is, now if you happen to be over 65 and meet with a road traffic accident in Colombo and have the fortune of coming to the National Hospital Colombo and you need ventilation, ladies and gentlemen, let me tell you, you won't be ventilated because you're over 65. So that should not happen. Health and social care managers, it's a integrated area where we have to work with many teams, not only doctors, nurses, physiotherapists, a lot of people have to get involved. And of course, one must never forget the caregiver. He is the focal point after the patient. A few demographics before I get on. The UN estimates that 30% of the world population will be over 60, and in Sri Lanka we'll have 5.1 million elderly, that is over 60 by 2031. And this is the slide, evidence-based slide. And may I draw your attention to the right side of the screen where it shows the sex ratio. You will appreciate that as you get older, there will be more females in the population than males. So that is also an important point to note in terms of demography. Since we're talking about dementia, I'm sure Asita will give you more details. For a population of about 60 million, the UK has about 700,000 people with dementia. 5% over 65, and when you take over 80, it's 20%. And of course, dementia is associated with the complex needs of high levels of dependency and morbidity. Therefore, it's a major challenge to the medical as well as the non-medical care providers. Basically, it's a major challenge for society. So how does one get old? You age. So aging is, of course, an inevitable process of anatomical, physiological, biochemical, and psychological decline, which leads to a total functional decline. Now, as primary care physicians, what we aim at doing is to assess this functional decline. So all our tools and all our skills is based towards this functional decline. And the handout given to you today will try to do that. And of course, you need to understand this process of aging because you've got to differentiate it from other pathological processes. For example, if a 70-year-old man comes and tells you, doctor, I used to eat 2 slices of bread, now I eat only 1, and he has no other problems, you've got to know how to interpret that data in terms of physiological function. Implications of aging population range from social to health issues. So it's a huge problem. So why should we, as in Sri Lanka, why should we as GPs or doctors, as citizens of this country, should be worried about the elderly? Because 67.3% of Sri Lankan elderly are financially insecure and socially dependent. That is, they rely on their children's generosity, donations from friends and relatives, and 13.5% do so on their pensions. So basically, they are financially totally insecure. So we have medical decisions and treatment plans should take this into account. Then the epidemiological transition, because we are going from a non-communicable to non-communicable pattern, so there in itself there are problems. Then clinicians' points of view. Now, if you go to a doctor, they say your elderly, they tend to tinker with the doses. They don't address the entity as a clinical problem. They are separate group of, now if you are say 40 or 50, you don't go to a pediatrician because it's special. So we need people to look into that. And the social and health capacity to handle this. So are we ready to handle this in Sri Lanka? As I told you, the speciality of the elderly is geriatrics. So then geriatricians should be looking after the elderly. And for the UK, for a population of 60 million, they have 1,000 geriatricians. We, for a population of 20 million, at the moment have 0 geriatricians, where we should be having 300. Then, ladies and gentlemen, who is looking after them? It is you and me. They come to the general practitioner. When they are turned out of hospital, they say, no, there is no room. They end up on your doorstep or mine. If they can afford, they might end up in a private hospital. But if not, we are the people who care for them. So therefore, it is imperative that GPs got to know something proper about geriatric care, specifically care of the elderly. So let me just quickly remind you the principles of our discipline. It's on there for you, and let me draw your attention to the bold at the end. It is patient-centered care versus doctor-centered. The doctor's skills should be used to address the patient issues. And let me get into the case scenario and give Asita the flow. Mr. Alfred, I call him Alfred, came to see me. He is a 70-year-old retired school teacher. He came up for a follow-up visit with his eldest daughter sometime last November. And he has been my patient for a while. He has type 2 diabetes, hypertension, and hyperlipidemia, all common things, nothing extraordinary about them. And with progressive target organ damage, which is inherent to those diseases. Whatever we do, the disease process goes on, because we only can mitigate it. So his investigative parameters were okay for his age, and he was on losartan potassium 100 with hydrochlorothiazide, atorvastatin, and insulin, and the ubiquitous vitamin tablet which all of our patients demand from us, so Bicosol. Then Mr. Amaratunga is a widower. He has 4 sons, 3 daughters, and 12 grandchildren. He lives with his daughter. He's financially totally okay. His wife passed away 8 years ago. But this visit tinkled a little bell in my head. because Alfred used to come alone all the time for his routine visits. But this time, he was bought by his eldest daughter. So it didn't seem right to me. So I'll tell you why it didn't seem right. Because after the consultation, his eldest daughter said, Doctor, can I speak to you? So in Sri Lanka, patient confidentiality doesn't work that way. I think family confidentiality is more important than patient confidentiality. Because sometimes they tell you not to tell their parents, all sorts of things. I don't know how far it is ethically correct, but anyway, I acceded to a request and said, yes, Mrs. Silva, what? Then she told me, Doctor, my father is forgetting. So then I asked, what? He said, no, he's repeating things. Like when you give his drugs, he said, no, I want to take it again. Then she said, he has difficulty in completing sentences. We have to prompt him. And also sometimes he thinks he's in Australia and demands to go back to Sri Lanka, when he's, of course, in Sri Lanka. So I, of course, concluded it was dementia, but I didn't know the details of dementia because I knew dementia is a progressive, largely irreversible syndrome that is characterized by widespread impairment. So as a primary care physician, my duty was to see whether I had caused this dementia. So there were reversible causes of dementia. Fortunately, the mnemonic is also dementia for those causes. So which are drugs, delirium, emotion, endocrine disease Mr. Alfred had, metabolic disease he had, eye and ear impairment, nutritional disorders, tumors, toxicity and head trauma, infection, alcohol, and arteriosclerosis. So having excluded these as causes, I had to get a second opinion from a tertiary care level or a secondary care level. And therefore, I spoke to Asita at that time, and Asita will now tell you about the story, about the dementia.
As Hanifa said, I've been involved. I've been coming to your sessions on regular intervals, and I'm very pleased to be here again on a Sunday evening. Before I forget, because I'm in the early stages of that, let me remind you, in 2014, I'm a council member of the Asian Society on Dementia. The 8th International Asian Congress on Dementia will be held in Sri Lanka. We put in a bid and we were awarded that this is in Philippines. So 2014 November, it will be held with the Association of Sri Lankan Neurologists, who will be co-hosting it with the Asian Society. So I would like, it's 2 years from now, but it's good if you can participate. It's the first time in Sri Lanka that you get a galaxy of international researchers and clinicians making their presentation, and we hope to have it over 2 days. All right, getting back to Alfred, his patient, as Hanifa said, it's defined as a global impairment of memory, intellect, and personality without impairment of consciousness, because if consciousness is involved, it is probably delirium. Now, what Hanifa described was usually that's a classic presenting scenario, clinical presentation of a patient. And most of the time, you may not get that clear-cut presentation. He had problems of recent memory. He was repeating himself, which is a very important symptom. He had problems with language, and he had some kind of visual spatial disorientation. So 3 domains, and that's pretty easy. But it can present in so many ways, and the subtle presentation is a difficult one to make a distinction, and that is when the differential diagnosis, which Hanifa put in there, matters so much. And please bear in mind very clearly that dementia or cognitive impairment is not an inevitable part of aging. It need not happen. So if there is decline, there is a problem. Number 2, not all dementias, not all cognitive impairments are Alzheimer's disease. There are more than 40 other causes. Now we recently, the International Work Group to Harmonize Dementia Treatment, we recently revised the diagnostic criteria, which was in 1984. And after so many years, in 2012, we revised the criteria. And even head trauma, which can be due to boxing, baseball, contact sport, is cognitive impairment resulting from trauma is dementia. And the biggest resistance we had was from the National Basketball Association of the US. They did not like it at all because they have head injuries and they didn't want dementia tagged to that. But there was so much lobbying, but ultimately the US guys managed to get around it. So there's so many causes involved. And Alfred has very clear presenting features. And if such a person is sent by a general practitioner, as he quite rightly said, we don't have geriatricians, so you take care of these guys on a day-to-day basis. As you know, there is no diagnostic test. We do not have a diagnostic test. Even after more than a century after it was first described, we do not have a reliable diagnostic test. A, to diagnose it, B, to even map the progression. So what the family tells people who move with them on a daily basis is absolute gold dust to us. So as a person referring such a patient for specialist care, I think it's very important that a family member, so that we can have a very clear informant interview, is made available. So if you're referring, it's best rather than write a huge note. Of course, that information is important. Asking a family member or somebody known to the person over the last 2-3 years who have detected the changes, be present at the time of consulting, is pretty important. And I mean, I'll skip these things, but the main problem of Alzheimer's dementia is loss of brain volume. As we age, it's known that we lose about 5 ml of fluid, about a teaspoon of brain volume each year. But in Alzheimer's disease, in dementia, it's far more than that. And the problem is we really don't know exactly why it happens. We know it's age-related. And the estimates are quite staggering. I mean, it's on average, the WHO believes that there's a case reported every 4 seconds in the world. And some people don't realize the scale of the challenge, the scale of the problem. And a lot of people believe that this is a problem that's seen in America and Northern Europe. It's not. If you look at the World Alzheimer Report of 2010, this shows the current sufferers in 2010, about 40 million globally. It's expected to go up by about 3 times that. And you'll see the majority of those patients, one in red, about 2/3, 60% would be living in developing countries, Asia, Latin America, because our demography is changing so rapidly. And Sri Lanka has not been spared of that. This is the United Nations Statistical Yearbook. I know it's a busy slide, you can't see all that, but take my word on this. This is life expectancy at birth. In Sri Lanka, the life expectancy at birth for the Asia-Pacific region, we are 11th from top, right here. Above are the countries like Australia, New Zealand, Hong Kong, and we're just below Guam. So our people live long. We've got at least that right. And we are way ahead of Malaysia, India, and regional countries. And as a result of that, we have to expect to see these people. We have to be aware that it's going to be around, and we have to be knowledgeable about how to manage them. As Hanifa quite rightly said, if you have this problem, whether it's a general geriatric principle or not, functional independence and quality of life remain key indices that we strive very hard to maintain, to manage. You may not remember, but you can do your own toilet. Your dignity is maintained, your quality of life is maintained. And that in turn relates or results in huge benefit for carers. So carer burden is reduced because somebody has to care for all this. If you lose your functional independence. So as a result, I'm totally in agreement. I'm delighted that you are focusing on this, because I believe that there has to be a national focus on this issue, because we are aging. This country is aging rapidly. And if that's the case, we're going to see these people. In 2003, Professor Saman Gurutilaka and myself, we led a study and we published in 2003 in the International Journal of Psychiatry, Geriatric Psychiatry, the prevalence of dementia is done with the University of Oxford. And we reported a 5% prevalence, which Hanifa reported, as Hanifa said, was reported from the UK. Our rates are no different to that of the West. The only country, the only region that has reported a very low prevalence was in India and in a very remote part of Delhi called Balabga, where they had 1.4%. And now we've reviewed that data, and we know it's probably because the life expectancy is not that great in those parts. So people died earlier. But here it's different. Our results are very similar. And we mapped a lot of other risk factors, genes and so on, and we are very similar to what's going on in the West. So you're going to see this more and more Alfreds and Mrs. Alfreds are going to come to you. And how we manage that together, yeah, I think it has to be a multi-pronged approach. It's not one doctor looking after, he's the specialist, so he takes care. No, that's not going to happen. That's impossible. No geriatrician, so I believe all of us should pool our time. And this is one illness that cannot be seen by a doctor who sees 50 patients one evening, because minimum time you spend is about 20-25 minutes getting the right information, doing the assessments and so on. Minimum. Without that, you're not going to get anywhere. You're making a mistake somewhere down the line because you've got to exclude so many causes as well. And this is how it usually presents. Very subtle, very insidious, creeps on you. If it's not vascular, of course, if it's a stroke, it's a dramatic event. You have a vascular event, and that's it. You switch on, you have a problem. But generally, Alzheimer's, since it's about 60% of all dementias, it presents like that. And Alfred comes around here. No, it's amnestic. He's had word-finding problems. But he's functionally independent. Hanifa didn't say anything about him needing support to wear his shirt, do his toilet, have his shower, shave, even handle money. Those are more advanced issues. But if untreated, it progresses. It progresses relentlessly. It's a neurodegenerative disease. There's no stopping it. And as a result, the milestones are very grave as the disease progresses. Cognitive impairment gets worse. And along with that comes the problem of activities of daily living, independence, and the psychiatric features. So it's a syndrome, actually. And they say there are 10 warning signs, which is what, if you go to the Mayo Clinic website, if you go to the National Institute of Aging website, any of the Alzheimer's Disease International website, you get that information. 10 warning signs. The presentation is usually memory-related, but it can be any of those. Funny behavior, changes in personality, loss of initiative, disorientation, poor judgment. He's a good man, he's doing things right, and suddenly makes a very poor call on his daughter's marriage or whatever, something like that. I had a patient who lives in Defonseca Road. The bank was the first trigger. The bank called the son and said, your father is issuing checks, unusually large denominations, cash checks. Check on this. He was giving the gardener 30,000, 40,000 rupee checks. And the gardener who comes once a month now came every other day. Fair enough. Why not? That's when it triggered, and because a lot of people have denial as well. They don't want to believe, they don't accept that there's a problem. And you make allowances. My father is aging, what do you expect? And as I said, I'm not going to go into detail here, there's a massive epidemiological study taking place in Bordeaux in southern France. It's called the PACWIT study. It's now in its 21st year of follow-up. There are people more than 65 just have been followed up, gathering information. And they're shown those who do not have dementia or cognitive impairment do not have impairment going forward. So the message is very clear that it is not an inevitable part. And it's a syndrome, as Hanifa said. It doesn't come just with one feature. It's a syndrome. It has problem of activities, behavior, as well as cognitive. It's ABC. Activity, behavior, and cognitive. So there's an involvement of all these areas. And then you give this it is a very dangerous label to give as well. We should not be cavalier or free to give that label. Okay, your father has dementia, your mother has dementia, your spouse has. It's a very dangerous label to give. We have to be very responsible when you make a diagnosis and say, are we sure it's not depression? Depression can be the same. Lack of initiative, problems with memory, no focus. So that once the referral has, forget about this, the referral has come to the specialist, this is what we have to offer the patient. If there is no treatment, you're going to go down. If you can someday find a treatment, offer the Holy Grail, the patient is going to be cured. And I believe from the evidence that I am exposed to in all these various associations and committees I work with, that is extremely unlikely to happen during my lifetime. And I have a reasonable time left, I believe. Arrest progression, I think that's also not going to be likely. I can give you the clinical trial data at some other forum, some other date. Not very good. Well, what we can do is what you're doing right now. Control the progression, symptomatic relief, which translates to two things: functional independence, as Hanifa said, and quality of life. And that directly translates to caregivers' quality of life. Otherwise, it can be a nightmare. So when the patient is referred, that's the objective that we have. I won't go down there right now. That's the objective we have to keep in mind. Make sure it's dementia, not something else. Try and find the cause of dementia if you can. There are different types. And of course, if you're sure, then you got to discuss with the family. Would you like to come here and do things together, or I just, how long do you want to go on for? 5 minutes, 10 minutes? 10 minutes. Okay. Are you okay with that? Am I boring you so much? Okay. So, as I said, there is no diagnostic test. There is even to diagnose or to map the progression. So we rely heavily on your referral note, on what you have seen over the years, all the metabolic parameters, history, and also the family interview. What have you seen over the last 6 months? And then the assessment is done. Whether it's MRI, whether it's a PET scan, whether it's a simple CT scan, doesn't make much difference unless you're looking for vascular reasons. Then you need MRI. Because whether you go to Pittsburgh Memory Center, which is a fantastic center for Alzheimer's disease treatment, or whether you do it in Colombo, the thrust is on a proper history, clinical assessment, and cognitive evaluation. Those are the main things that we have to go by. And cognitive assessment, MMSE, everybody knows, everybody likes it. It's not the most accurate, it's not the most sensitive. Because all cognitive assessments are education bias. It is how you perform is determined by your background education level and your social sophistication. As a result, you need a bigger, a deeper, more comprehensive cognitive test battery which assesses different aspects of your cognitive ability: temporal orientation, episodic memory, semantics, abstract thinking, judgment, planning, visual spatial perception, word finding, all those. And that takes time to do, across the table with a person who knows what to do. And once that is done, and it's not so much scoring, it's having 65 and below 65 is dementia, above 60. That is also being shown not to be so clear cut. Because if you're educated, your score is higher, naturally. So you don't go as much as by the cutoff for a score, but by the feel for what you're getting when you're doing it in front of the patient. And this sometimes can have a devastating impact on the family. They've never seen this because the assessment is in depth. And when the assessment is being done, it can be really devastating what the family can experience here. So it's up to you to decide whether you want the family in or tell them. During the assessment, you might come across a serious deficit that your father is having, Alfred is having, and be ready for this because he's going to be unmasked. So once you do that, then it's a case of having supportive information. If you have done the thyroid, we simply depend a lot on the thyroid profile. You can ask for the B12 and homocysteine levels if the patient is a vegan. Renal function, liver, if there's a history of alcohol. And CT scan is very useful. Non-contrast, that's the plain CT. The CTs are very good these days. But if you're having, this patient has a large, significant vascular risk factor, as Alfred was having, diabetes, hypertension, Then maybe an MRI to look at whether there's small vessel disease, lacunar infarcts. Lacunar infarcts are very, there was a time when lacunar infarcts were not recognized as significant, but lacunar infarcts are now considered to be very important. So lacunae, small vessel disease, multiple small infarcts in the brain, deep white matter ischemia, they're all significant. And once you have that information with you, you have a reliable understanding, okay, Alfred is probably having Alzheimer's disease. It's either possible or probable. You make us take on that. So what do? You have the diagnosis with reliable accuracy. Remember, it's a post-mortem diagnosis. Ante-mortem diagnosis, whatever you do, is about 90% accuracy. There are tests being developed to map the amount of amyloid, because you know that there are 3 pathological hallmarks of this illness. Deposition of beta amyloid, intraneuronal deposition of tau, or the phosphorylated protein in the neurons called tau, both of them resulting in neuronal loss. That's why the brain shrinks so much. So in Pittsburgh, they have come up with a substance called Pittsburgh compound B, PIB, Pittsburgh compound B, which is a radiological tracer. Patient is given that, or anybody, you and I can go and take it. And they have special PET scans because this radioactive material going tags on to the amyloid in your brain. All of us have amyloid, certain amount. And you take the scan, and then the amyloid just lights up. So if you have a massive amount of amyloid, okay, you're either demented or you have massive potential to have that problem. But the problem is even that is shown to be non-significant. I mean, I don't have that, okay. It's not as significant as in terms of sensitivity. You might have, for example, CT scans showing significant cortical atrophy, especially around the temporal lobes, because this is Alzheimer's disease is temporoparietal primarily. So you have the hippocampus, the choroid, that area being affected. So neuronal loss is mostly around the medial temporal lobe, the hippocampal region. Some people have significant loss of tissue there with normal cognitive function. Some people have perfectly normal CTs with massive cognitive impairment. Same with Pittsburgh compound B. So it's so undependable. If you have a diagnosis, if these things are getting positive, they're having a significant CT scan from, yes, then it helps because you're confirming your diagnosis. But you have to be very lucky to have all those things working in one direction. You don't most of the time. Because Sanjeev Munisinghe will reply and say, unremarkable CT scan, or maybe just age-related atrophy. What do you take on that? Nothing much. But you have a clinical problem here. The family is saying this is a problem. GP has noted the problem. You have seen this man for so many years. And I am seeing him for the first 30 minutes. So I cannot overemphasize the value of what you have seen over the 5 years you have taken care of Alfred. And once, let's say, we all agree, I believe we have to communicate with you. I know it doesn't happen. I try hard to do that. Whoever reports to me, giving reasons, what I have seen, this is what I plan to do, because the patient is always going to go back to you. And all good patients must go back and check with you. So this guy is saying all this, should we go ahead? And once we have an agreement, yes, we must start treatment. And I said the objective of treatment is to try and delay the progression. And that's when I believe communication is very important, because you've got to talk to the family and say, this is what we are going to achieve. Believe me, they go from doctor to doctor. Like all of us, they do the doctor shopping. They do the full and every consultant, every specialist starts something new. At least a different cholinergic drug will be introduced, just to make it different to what the other guy had given. Or do another test that does not. That's natural. We do that all the time. So explaining to the family, this is what your father has. If you are people, sophisticated people, go and check this website. You will understand more about it. And this is what you're trying to get. In 6 months, in 1 year, if you come to me and say, my father, Alfred, is still forgetful, slight problem with word finding, but he just goes for his walk, he still buys the newspaper, gets the correct change, comes home, very sociable. He has a drink on Sunday night, which I'm hoping to have soon. That's fantastic. So you tell them, this is what we want to achieve. If he can do that, 6 months, 1 year, 2 years, 3 years down the line, we have got it. So look out for that. And you prepare the family, you tell them, you communicate, and ensure that they understand, and then start treatment. And we have 4 drugs anywhere in the world registered for Alzheimer's disease. 3 of them are cholinergic, centrally acting, and 1 is NMD receptor blocker. So the mainstay of treatment right now in the world is to augment central acetylcholine by blocking acetylcholine esterase. This is just basic physiology for all of us. And the 3 drugs that we have in the world licensed, donepezil, rivastigmine, galantamine, these are the 3 that will block acetylcholine esterase, increase the level of acetylcholine in the brain centrally. And of these, donepezil and rivastigmine are registered in this country. Galantamine is not. The NMDA receptor blocker, memantine, is also not. But, like everything in this world, memantine can be found if you know the right pharmacy. And I believe it's all illegally done, but that's a different matter altogether. As registered medical practitioners, we can recommend those 2, and Exelon is rivastigmine. The results of what you treat, this is from donepezil, but I can just easily replace that with rivastigmine. It doesn't make a difference. What we see is this. Across the board, I told you there are 3 things to look for: cognition, activity of daily living, psychiatric features, personality. There are scales for all of these. So what we're trying to show here is the result from clinical trial. Here is the person, this is the scale of cognitive evaluation, A-COG. It's a very decent assessment scale. This is time, the treatment was started here. This is the point of presentation, this is Alfred. And once the treatment is started, most clinical trials have gone up to 6 months, 1 year maximum now, but not much has been done for 1.5, 2, 3 years. So the evidence we have is up to about 6 months to 1 year from clinical trials. What happens over the next 24 weeks is usually this. If you don't treat placebo, Alfred will go down. His cognitive ability will impair further and further and further. But with the cholinergic drug, with Exelon, rivastigmine, you will see that the person improves or stabilizes his cognitive ability. And that is what we try to explain to the patient and try to tell them that this is what we are trying to achieve. Because remember, we are making the diagnosis. Alfred has been diagnosed at this stage, where he has amnestic problems, word finding problems, only maybe subtle changes with his activities of daily living. He's getting disoriented in his house. He's not sure where he is. That's when the diagnosis has been made, right at that point. But it is progressive. It is irreversible. So if we treat here, we try to prevent him from going down. But that's a long story. And if we succeed in doing that, that's good. But why? This is why the explanation of the family is important. Why cannot we bring him back to normal? It is not possible. It won't happen. If it happens and you got your diagnosis wrong, you're treating depression. Or he had a bad day and he's just come back to normal. There are people like that. I've treated, I'm not ashamed to say that, something looks a classic, come and absolutely, I had a Maldivian patient, they believe I'm God. And they come all the time and I think to myself, did I get it wrong? This guy is doing so well. Well, it may be a miracle, I don't know. And once you achieve that, because the diagnosis has been made at a later stage, remember, I'm not going to go into that, there is a huge lack of clinical and pathological concordance of this illness. The pathology establishes itself before the symptoms start. So if Hanifa is going to be demented at, God forbid, 65, 70, the process has already started. This has been shown by the research done on all the Down syndrome cohorts in different parts of the world, where they share, there's a pathological sharing of risk factors for Downs and at least genetic risk factor sharing, Down syndrome and Alzheimer's. The clinical pathological process has started way before the presentation, the symptoms appear. That's why we can't cure it. That's why we can't treat it. That's why we can't successfully reverse the problem. And if you keep that in mind, then our goal of treatment, what you're trying to achieve is very clear. And a lot of patients then ask you, what can we do in addition to this treatment? Can we do anything? Because remember, we're diagnosing it at that point. Pathology has started. This is when Alfred has come. It's going to go down. This is a little window of diagnosis we are having. And we're treating here. And if we can push this downward slope slightly to the right, that's what we're trying to achieve. So that he's got functional independence and quality of life. Do you want me to go there? Not necessarily. So we refer back to Hanifa and say, this is the patient, this is what I can do, here is the treatment. And know what the drug can do, explain to the family, because sometimes they feel it's a futile exercise because they treat for 3 months, 6 months, 1 year. He is not improving. You've got to tell the patients, that is what we are trying to achieve. Otherwise they give up. They spend a lot of money on these medications and they give up. And I see a lot of patients just started on 1.5 milligrams twice a day on Exelon, and then they just go on. And 3 months later they say, my father is not getting better, the doctor says, useless, throw it. No, you've got to escalate the dose. There are certain things that you do, and that's when the GP and the specialist starts working again. Because there are some side effects, adverse events, mainly related to the peripheral effects of cholinergic peripheral activity, nausea, little bit of vomiting, gastrointestinal GI disturbances. They're not very sinister. I mean, I haven't come across a very serious adverse event with any of these drugs. So the GP gets in again, referred back with a diagnosis, started treatment, then you got to manage, because I'm going to see once in 3 months, but you're going to see once a week, once in 2 weeks. Monitor, follow up what's going on, keep assuring the family, this is where he's going, we are doing right, don't worry. And of course they keep asking, can I get it? This is genetic. Should I do something about it? In addition to the medication, should my father do something more? Activity is the best thing to do. A lot of people believe, not me. Control your risk factors, control your cardiovascular risk factors. Keep your blood sugar, keep your blood pressure under control, keep your cholesterol low as much as possible. Go for your walk, improve your circulation. Have a little drink in the evening, red wine if you like, or something stronger. Nothing wrong with that. Believe me, there's nothing wrong with that. I believe in that. And, no, seriously. And can I get this illness? Not necessarily. Is it a gene involved? Yes. Should I screen? Discourage. They can screen, but discourage. So that's when the GP starts all over again. And I think it should be a two-way process after that. Once in 3 months, specialist, and the GP generally managing the whole, and keep assuring the patient we are achieved and we are maintaining the goal of therapy.
Thank you, Asita. Okay, now once Asita has sent, we'll come back for questions, don't worry. Asita has painted a gloomy picture, but when the patient comes back to us, we need to work with that gloom, or what we can do. So let me tell you, that's when we start weaving our magic, Asita. So this might be relevant. So what do we do? No doubt there's shared care. Asita will see my patient probably, hopefully for a very, very long time. So this is our bit. Asita is looking after probably the physical, mental problems mainly with regard to the patient, his memory, cognition, and so on. So who looks after Alfred? That's me and you. We look after Alfred. So what do we got to do with this Alfred, with Asita has diagnosed as Alzheimer's dementia? So what do we do? Cure, like he said, is out of the window. Prevention is history. So we have only today. What do we do now? So we got to think of Alfred, his family, and like Kasita said, all of us have to get involved, the community. So what do we do? He spoke about activities of daily living. So let me just run down them quickly. Activities of daily living are, of course, eating, continence, toileting, bathing, dressing, transferring. So we got to ensure that those things are not deteriorating by a functional assessment, which you have got the tool to now. So instrumental activities of daily living, he mentioned taking change, shopping, using a telephone. Probably when I get demented as using a computer. It might be an instrumental activity of daily living because telephone use, say 50 years ago, it was a luxury item. Today it's an instrumental activity. You got to know how to use a phone. So that's up there for you. And there are many, many tools like in Asita's world. We too also have developed so many tools, all theory based, totally biased by your educational, social, and cultural backgrounds. All these are Western things. I think, Asita, you have developed one for Sri Lanka, right? Yeah. Asita and Professor Saman have developed a validated MMSC for Sri Lanka. So that's available. We can use that. If not, there are all these theoretical things which you can fill an encyclopedia with. But, unless you're into research and things, we don't use. So what a busy clinician should do, and primary care have tried to come up with something for you. I hope it will be useful. It takes the physical and mental things together, puts it together, and gives you an idea, the feel for the patient. Try to recreate it on paper. Hope it works. So why do we need to assess? Because we can increase the diagnostic accuracy. We can give people like Asita more information. Then we can also share our monitoring with improvement or decline with the specialist. And of course, to increase the health outcome, survival of better quality. I feel as a general practitioner, you have not seen your patient until you have visited him in their residence, especially with elderly patients and more especially with demented patients. You got to see, you can't be a remote control, you have to go in there once in a way at least and have a look at them. Why? Because in such visits, you confirm the ability to comply to medication, assess caregiver capabilities. The daughter might not tell you she is under stress, but when you go home, you pick up little things where the family is under enormous stress. Probably when you open the gate, you would know. Little things you got to pick up, totally unrelated to medicine, but has major impact on your management. Then access to facilities. They might tell you, no, doctor, we can buy the drug. But when you visit home, they can't buy the drug. So that is your family physician role. Then you say, Asita, listen, chum, a drug is not working or they can't afford it. Let's think of something else. So then he will advise us appropriately what to do. Then there are a few points. You should not discriminate them. I told you this before, just because they are demented or aged, you should not deny them any, say, Asita wants a thyroid function test, you shouldn't think, no, this guy is demented, he doesn't need one. Or probably a CT scan, there is no use of doing it. Or a simple fasting blood sugar. He is demented, what's the use, couple of years more. So don't do that. Then this valid consent has far more than what it says. Health and social care practitioners should always seek valid consent from people. These are massive, massive ethical issues in dementia. If you can't get the patient's consent, you've got to work out a way of doing it. It's probably even legal. I will speak of caregivers a little more in detail. Then coordination and integration of care. I have showed you the 3D model. Actually, I am proposing even a 4D model. It's not in textbooks yet. Hopefully, I can get my name on it. The fourth dimension in this holistic care is ethics. We talk of ethics always separately, but it should be in there. This 3D model should change to a 4D model because ethics got to be there. There are a lot of ethical issues in treating these patients. And memory services. Do we have any memory services in Sri Lanka? So we can ask Kasiti at the end. So we can offer that to the patients. So what do I anticipate once he comes back to me? He's going to be with me for a while. So these are the things I got to watch out. Atypical presentation of common problems, frailty. Frailty is a new concept. It's now getting into textbooks. It's mainly in journals these days. It's a clinical diagnosis you got to make. Then mental health problems, which he has dealt with one aspect. Falls, sleep, loneliness, maltreatment of elderly. You only got to check the newspapers in Sri Lanka or anywhere in the world. Then care of the caregivers. So I'll quickly go through these. Atypical presentation of common illnesses. Infection without fever. Fever without infection. Things like that, due to, please remember the definition of aging. There is anatomical, physiological, and biochemical changes and going on. So your immune system is not working properly, your thermoregulation is not right. So all these things kick in. So you can have a thundering infection with a UTI, patient might come confused. So you might think he has delirium or whatever. So you treat the UTI, fever settles, patient is back to normal. Or he might have a fall due to the confusion and incontinence. So fever without infection with age made partial or complete intestinal obstruction, very common in the elderly age group. Then bowel problems due to constipation and so on. Yes, frailty, I'll take a few moments on this slide, is defined as dependent on others for activities of daily living and instrumental activities of daily living. I think by that definition, most of us are frail or have been frail throughout our lives. But then there are some core elements you got to look for. That's weakness, tiredness, poor endurance, weight loss, low levels of physical activity, and slow gait. So these are not hi-fi clinical stuff. These are just simple observations. They are not even symptoms or signs. So like in family practice, we like to keep it simple. So these are colloquial layman's terms even which we are using in the diagnosis. So if you have more than 3, you're frail. And please remember, frailty is not due to any pathological process, though it might be. So it's a completely independent entity. Mental health problems, yes, the 5 Ds, delirium, dementia. Asita has spoken about it extensively. He has touched on depression, delusion, and distress. So we might have to sort these things out as well. Falls. Yes, falls, the definition is there. There are many factors. But the take-home message on falls, I would like to give a general practitioner, is when a patient falls, we are not the people who do the hip transplant or the knee transplant or, put a plaster of Paris or vascular surgery. What we got to do is to address the fear of the next fall. Because the fear of the next fall is going to change this Alfred's life completely. Absolute impact on his life. Just fear of the fall. Just to digress a minute, if I see 100 patients with fever, say over a period of a month or so, and I would see 100 cases, they all will say, "Doctor, do I have dengue? I need not know how to treat dengue. I need to know how to treat the fear of dengue." Same thing here. If you do not address this fear of fall, as a primary care physician, you have failed in your duty. You can diagnose the fracture. My medical student will diagnose the fracture. Probably the bystander will diagnose the fracture. But if you do not address the fear of the next fall, you have missed the bus. So that's the message about falls. About 50% of over 65 have sleep problems. And this is quite distressing to even the others at home. So it causes a lot of, stress levels to build up at home because this elderly gentleman or lady is at 2, 3 in the morning walking around the house, switching the lights, opening the doors, opening the fridge. So, it's a big problem. And in fact, recently I treated a priest whose grandchildren brought him to me. This was a problem. The temple people had said they can't keep him in the temple anymore, so to do something. Loneliness, very, very easy to pick up. Verbal outpouring, drab clothing, dependence on TV, radio. So we need, like Asita said, we need to get them out there, go for a walk, buy the newspaper, ensure that the activities of daily living are on track. Maltreatment of elderly. I thought I will mention this deliberately. The global estimates say that 1 to 10% of elderly population are maltreated. It's not, that they are hit or anything like that. It's verbal abuse, how you look at them, how you treat them. So the son used to come to visit him once a week. Now, though that he's demented and it's difficult to speak to him, he tries to avoid coming. So these problems are there. So they are not easy to deal with, but they are there. Then, of course, we have heard stories of elderly gentlemen being chained in the front yard with a chain, with a radius where he can go to the toilet, kitchen, and things like that in Kurunagala. I can give you the paper cutting, but I didn't want to put it here today. These things do happen. Then if you put them in an institute, like there is institutional abuse of orphans and so on, it's very common in all over the world, not in Sri Lanka. Then drugs in the elderly is a problem. The quantity they take is enormous. I think once with a couple of medical students, I measured, we actually weighed the drugs over a 3-month period, and it came to about a kilo. A kilo. Nephrologist, and I don't know, whatever other logist. Same drug given by 3 people, patient is taking all 3 drugs. So it is our duty to do a pharmacological review of these things. Won't take 20-30 seconds of your time. And that's what we record. You just cross-check with your records and see what's the new drug they have put. So you can pick those things up. Then this new problem of, because majority of the elderly population in Sri Lanka are now alone, children are abroad, so they feel guilty. They send them all sorts of supplements and vitamin bottles of container size magnitude, and they turn up in your clinic. Doctor, what do you know about this? Well, I say I don't know anything about it because I don't. So then you say don't take it because you don't know. In fact, recently I had a patient with increased LFT levels, wondering why he is taking paracetamol imported from the States. Here it's 500 milligrams a tablet, there it's 750 milligrams a tablet. So he's happily taking 2 tablets with high LFT levels. So very common. So if you have unexplained biochemical values, better review the drugs, especially in the elderly. Yes, health promotion and disease prevention, like I said, you should not penalize elderly people. Even if he's 70 and smoking 20 packs a day, tell him to cut down or stop smoking. If he's not exercising, tell him to go for a walk. It's worth it. Because repeated studies have shown even at late stages it will improve the quality of life and life expectancy itself. Yes, now getting on to the end of the slides, we all have to go. That's what we heard over the last 2 days. So we have been trained as doctors to sustain life and cure disease. Right? So what we are doing is we are trying to increase life. But actually what we are doing is we are prolonging the dying process. That's not my quote, it's from Dr. Suresh Kumar, he's here. Actually what we are doing is we are trying to increase the process of dying, the time of the dying process. So we need to change this because NCDs cannot be cured. You and I know that. So we got to manage them and give them a better quality of life. So how do we do that? These are the definitions. So we got to think of palliation. How do we control certain things? How do we incurable cancer? You know, it's by definition it's incurable. So what do you do? This is the definition of palliative care, and I'm not promoting the course for one moment, but it's a specialized area to know about. Just to ask you, there are 3 ways of dying. Whatever way you choose, we go one of these 3 ways. Which way would most of you want to go? First one, second one, third one? Yeah. Unfortunately, Asita, only 10% can do that. So I think we have about 30 people here. 3 of us will be lucky. The next 3 of us, the next 27 of us have got to face either this B or C. So if I'm not in the 10%, I would rather choose C, where you fade away. So, you don't just fade away. So what type of cares are involved in fading away? The middle one, yes, you go into hospital, you're in, you're out, you get resuscitated, you get ventilated, then you come back to normal, you go back. I don't know, I wouldn't want to go that way. So then if you want to fade away, the type of care involved is palliation. You palliate and fade away, where you are prepared for your death, where it's discussed with the family physician or your doctor. Your family all are involved. So palliative care, like we heard over the last 2 days, is very, very important for primary care physicians. And you might think when we say palliative care, it's mainly after cancer. But let me tell you that the commonest need for palliation is age, elderly care. That's where the main focus is, though the mechanism of delivering it is maybe through cancer control or whatever. But day-to-day primary care physicians are heavily involved, so they got to know something about palliative care. So end-of-life principles, yes, can skip that. And the most important part of my presentation, care of the caregiver. I know Asita looks after the mental aspect of Alfred. I look after Alfred. Who looks after Alfred? We as family physicians have a duty because we see the deterioration of the bystander. So we, living in Asia, we have a social structure. So what I encourage my patients, even Alfred, what I encourage to do is, okay, probably I'm responsible for him thinking he's in Australia. So 3 months you stay with one daughter, another 3 months with another daughter. So, you give the caregiver also some relief. Even if it's a paid caregiver, see that that guy gets some leave, proper leave. If not, he will start abusing the patient. And we have seen this over and over. I have seen it over and over again. So our close-knit Asian society is really good. We don't have to have social service organizations to take care of these elderly, take them on a trip. Recently, I read an article, I think I circulated among my colleagues. Germany is building resort homes in Thailand and Vietnam to ship their elderly to live there. It's cheaper for them to do that. So we can't even think of it, but we do have a very close-knit structure. And when you send an elderly, your grandfather or whoever to that, he'll become useful again. He might at least open the door or answer the phone when the phone rings. Go and open the gate when somebody comes. Pick the kids up from school, just walk. So he is also, again, given some purpose in life. So this thing, shifting the elderly around is a good thing. And see that they go to the clinics and required medical attention as required. So caregivers have physical and medical problems, psychological problems, social issues, and economic issues, which you can help up with. With particular reference to dementia, caregivers of people with dementia who experience psychological distress and negative psychological impact should be offered psychological therapy, and which includes CBT, and of course specialist referral also you might have to do. So I think we have kept the time, Asita, very well. We have 10 minutes for questions. So due to epidemiological and demographic transition, I have showed you the problem. The needs of the elderly are immense, and we have concentrated on one particular area today. And end-of-life care and palliation is also there. And let me conclude what we need to do and what Asita and I have in fact done today. The cognitive symptoms and maintenance of function, this middle bit is in your handout. So that's what we didn't go into detail with that. And we do have a validated mini mental scale for Sri Lanka, which Asita and et al. Have developed with their research. So you can access that as well. Thank you very much for your attention. If you have any questions, I'm sure Asita would be delighted to answer them on my behalf as well. Yes, sir. Asita, would you like to join me? I think it's for you anyway, the question.
But I have many questions, but I'm more interested in Alfred's daughter. Now, uh, several things regarding the daughter. One is that uh, suppose she's around 50, 55 years and she wants to prevent herself getting the getting dementia or Alzheimer's, whatever. Uh, you came almost up to it and you didn't proceed from there. Is there something to take to prevent it happening? That's one. Secondly, uh, Hanifa, you were perfectly right. You have to visit the home. And when I visited the home of one person, the daughter was absolutely exasperated with the mother. Now, uh, you know, shouting and doing all that. Uh, you can't blame the person also because, you know, the elderly person is accumulating plastics. All the ice cream boxes and all they are all put in the front of the house. But the person is absolutely exasperated, so angry to an extent that this morning I had a call from a lady asking whether she can come and stay with me. uh, Now, shifting to other places is not always easy. Sometimes you have a one child uh, to to a single parent. Uh, Hardly any cousins. What do you do? Because the person is just unable to do his normal job because of this dementing parent. Those are the three things.
Prevention, if I take the first one, there's nothing. I mean, if you look at the causes, I came there. It's multifactorial like any other disease, like heart disease, like diabetes, like breast cancer. It's multifactorial with a heavy genetic preponderance. So there are genes involved. We can't choose our parents, as I always say, unless you're Prince Siddhartha. You can't stop your aging process. Age is a huge risk factor. So you have the so-called modifiable risk factors. And believe me, the only evidence base we have for modifying those risk factors are related to controlling your vascular risk factors. Your vascular risk factors, the same risk factors you have for heart disease, are the ones that should be controlled, that have produced. I removed it, but I can give you all the results of clinical trials and follow-up studies done, progress 1, progress 2, and so on. By controlling your blood pressure, diet, Mediterranean diet, your blood sugars, cessation of smoking, that's what is proven to be useful in trying to prevent this. So that's the focus now, because we don't have a cure. Prevention is aimed at controlling your vascular risk. And it has been very clearly shown by some colleagues in the US that the vascular risk factors are cumulative. So if you have smoking as a risk factor, if you have vascular smoking and diabetes, the risk of getting dementia further down is increased. So controlling that is the only way in which you can address this prevention story of Alzheimer dementia with evidence. There may be other ways of doing things. Coconut oil is supposed to be something that is supposed to be good. Virgin coconut oil. I don't know. Anecdotal reports, no clinical trials. But definitely control your vascular risk factors. Family disaster at home, yes. I have had one lawyer, daughter in Ratmalana, who attempted suicide. He's a lawyer, attempted suicide. Well, in that situation, alone in family, nightmare at home, we have to introduce atypical antipsychotics. The atypical antipsychotics, you've got to control this behavior because it immediately transforms to caregiver well-being. And quetiapine is the safest we have. Both quetiapine It's a new atypical, and it's new as it's newer than risperidone and olanzapine, because olanzapine and risperidone have a CSM warning about risk of increased cerebrovascular disease, and olanzapine impairs your blood sugar. It's a very dirty drug. So quetiapine is what we have. We have to control that. We got to make them sleep. We got to calm them down. There's no choice. Quetiapine, Quetiapine, quetiapine. Dose. Up to 200 milligrams twice a day maximum. We start at 25 in the night and gradually work it up at 24 intervals. The family can titrate it. 25 in the night, 25 BD, 50 in the night, 25 in the morning, 50 BD, and so on. 200 twice a day maximum. I just add two things as GPs. I think what you should do. I'm sure Eugene will agree with me. When you detect Alfred at this stage, I think you've got to talk to the family about settling all the legal matters. You don't want to be dragged into a massive court case. And I would urge anybody I meet, doctors, not to tell the patient that there's nothing we can do, go home and drink yourself to death, or have a blast and die. There is much we can do. Even today, doctors tell them, well, that's it. There's nothing I can do now. You can tell them it's incurable, but we can give them goals of maintaining what they have. And Alfred stage is the best stage to get the legal side sorted.
About alcohol, you were saying that, also was saying red wine and those things help. But there's also the finding that alcohol can accelerate brain atrophy. So I don't know how you fit that into that.
Moderation.
Yeah.
Moderation.
So do you make a
It's part
difference?
of the Mediterranean diet.
No, do you make a difference between strong alcohol and
No.
wine?
Well, red wine is supposed to be something different. I just believe it's C2H5OH at some stage or the other in the body. But yeah, red wine if you can. But I'm not encouraging people to drink, by the way. I'm just saying if Alfred is 75, guys had a drink in the night, I'm not going to tell him to stop it. He's going to kill it. He's going to die of depression with that. That's what I'm trying to tell you. It's not going to kill him. It's not going to accelerate the disease. If he's taking half a bottle of arak or whiskey every day, that's going to be bad. It's going to screw up his blood pressure as well. But not the one or two drinks that 25, 50 ml. That's okay. The vasodilatation, some benefits. But I'm not saying go and start drinking from tonight. I'm saying if you are a guy who enjoys a social drink, there's no need to stop it.
Yeah, second question is, what are the drugs that can accelerate this process of Alzheimer's?
I just checked up, there are 136 drugs. There are 136 drugs which can do this. It's available on a site. You just check dementia acceleration. Common drugs are metoclopropamide. Then even Benadryl cough syrup, that also causes, and 136 drugs.
What is your experience with tramadol and those drugs?
Can I get a tramadol? Well, the opioids. I don't know about dementia, but they cause confusion, delirium. Those are known to be caused. I do not know the evidence on dementia, but opioids are known to cause confusion, delirium, that spectrum of things. But I don't know about the dementia evidence.
I mean, giving a drug for a short duration of time on requirement is not going to do anything. Of course, if you have something like a thiazide diuretic and you it cause hyponatremia, that is going to worsen the confusion. You know that. Otherwise, giving a 1 week of this, that, and the other won't do anything.
Also, I think what is suggested about alcohol is also applicable to many of the drugs. Because we have to balance between the possible benefit that the patient can get and and possible damage it can cause in the lung.
Can I just, as an elderly GP, talk about some problems in the elderly that are relevant, I think, which have been touched on? One is, of course, the importance of the bystander or the person who comes with the patient. Now, Hanifa, you touched on it very effectively. I think it's a flag. If you find a person who has been usually coming to you alone and confident of himself is suddenly either accompanied or finds, presents in a different way, that's a flag in general practice, right? So I think that's very important. And as for the alcohol, I think I would be more worried about, after my experience, about the alcohol level which is found in Alfred's son. This is another Alfred. I'll just stand up because I think I'm speaking in a rude way. Some time ago, I had this patient who was in his 80s. He was having fever, and he was brought by his son. And for some strange reason or other, his son got him to sit by me, and he went behind. And he was some distance away. So I very religiously took the history, and I found he was having fever. And the son from over there said, "Doctor, he drinks." And I went into, my usual sermon about alcohol, and you should not be drinking, this is very bad. And the old gent listened to me very nicely and smiled, and he went away. 2 days later, the old gent came with his daughter, and his fever had subsided. So I asked the daughter, "What about your father's alcohol problem?" She said, "Doctor, he has never drunk in his life. It's my brother who drinks." So the brother was outside, and he was telling me that the father was drinking. So this is not unusual in general practice. The other problem I would like to just raise is, coming after Suresh Kumar's and Saif's expert opinion about death and dying and terminal illness, sometimes it's darn difficult to decide when a patient is dying or terminally ill. I have a couple of examples. Some of them are really tragic, but I would like to say something that is more suiting for the moment. My grand aunt had COPD, and she had come to me, and she was residing close to my house, and I found that she was gasping, and I felt that she was dying. And I got a colleague, of course I was very careful, I got a colleague also in the area, and both of us decided, "Machang, she's dying, so let us do what we can do." So I told the daughter, "You go home." They lived about 20 or 30 miles away. "You go home and prepare things." So immediately off she sped to get the garden trimmed and the house color washed and, ready for the funeral. The unfortunate thing was, or perhaps the fortunate thing is, that she lived for 5 years after my diagnosis of death. And sometimes I thought this was something wrong with me. But Dr. J.B. Pires himself one day told me, it's darn difficult to decide when a patient is dying. And I think the icing on the cake was when Denis Aloysius told me that he had diagnosed that a patient was dying, and that patient survived for 10 years.
Just take home message if you like. If you have a patient with Alzheimer's dementia, please remember it's a progressive, slow decline. If there is a sudden deterioration of his cognition, please investigate. There is something underlying. It doesn't just drop like that. Most of the time, as Hanifa said, urine tract infection.
The academic part of the program is now complete. I think now there's a message from our sponsors.
It has been a great pleasure meeting you again. Could you excuse me? I have a drinks party.